must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show. Hey, everybody. Welcome to another episode of the HET podcast. I am your host, Brandon Powen, and today I am really happy to welcome a very prominent and well-known SCCE to chat about kind of her perspective being an SCCE, along with kind of her experience perspective on clinical education from her perspective. And with that, I have the distinct pleasure of welcoming Dr. Chrissy Ropp. I also want to give a personal shout out and thank you to Dr. Carol Beckel for recommending Chrissy for this episode. And I thought it was funny, Chrissy, when I first reached out to you and Carol told me about you that we were with OSF because two of my clinical sites for my clinical education were with OSF. So it was good to see a familiar name there. But I appreciate you taking the time to chat today. And, thanks for coming on.
Sure. Thanks for having me, Brandon. We at OSF really value education, and the administration has done a lot to support fostering clinical education in rehab disciplines, just as well as medical education. And have us not be seen as kind of a tag along and develop our curriculum and our program in its own right.
Yeah, and I'm excited to kind of dive a bit more into that because your perspective, I'm sure, is very unique and distinct, which I love. But let's back up a little bit and let's just kind of set the stage a little bit. Would you mind sharing a little bit more about kind of your story with kind of how you got involved with OSF to kind of where you are now as the rehabilitation clinical internship coordinator?
Sure. I am from Peoria. Peoria is the location of the largest OSF medical center. I actually worked as a rehab tech there before I went away to school. I always knew I wanted to go into physical therapy. So I got some really great on-the-job training as a tech prior to going away. When I went to college in the late 80s, it was extremely competitive, and there were not as many programs as there are now. So I didn't get into any programs that were really close or commutable. So of the programs that I went into, I decided to take the big leap, and I went to school in Los Angeles, which was really interesting for me because it's in a very different healthcare environment on the coast than it is in the Midwest. So that was eye-opening and really educational for me. I also, though, had signed a pre-employment contract with OSF. So at the time, I came back and committed to work there for 2 years. And I always thought Peoria was a small town, so I was really planning to fly the coop and go back to a big city. But something happened, and 25 years later, I am still in the Peoria area working for OSF. So we recently went through a reorganization within rehab, and we report up through a rehab chain of command. So we don't report to the entities at each facility. We report through a rehab structure, and then we have a senior vice president who is a PT who sits at the table of the board with all of those facility presidents. So rehab has a really strong presence within the OSF network, and I really like that autonomy that provides our therapists.
And Chrissy, I kind of want to, because we haven't really actually had someone from the position of an SCCE really on at this time yet to kind of get their perspective on education and clinical education. So let's start at the beginning because I think we got to get an understanding of kind of what SCCEs have to do. So would you mind kind of sharing a little bit about what you specifically have to do for this position, just to kind of give some context?
Sure. So there are no formal requirements to be a site coordinator. Basically, you have to have a heart rate and be breathing. There's also no formal training. That has changed a little bit. There's some collaborative programming that happens at the Education Leadership Conference each year on new site coordinator training. So experienced site coordinators, such as myself, present content and act as a resource for developing programs. Some SCCEs don't have any administrative support, so they actually do their role in addition to full-time patient care and or full-time mentoring. So that might look like a clinician, has a passion for education, and they essentially do this role on the side. So the site coordinator ideally coordinates the clinical rotation. So you want to make sure you know capacity issues at your clinics, how many students can you have, who has strengths in mentoring students, who needs guidance to do that. There are a lot of administrative duties, validating the requirements as far as vaccinations and CPR, those kind of things. There is a lot of communication that goes out. Students are very anxious before they come to their rotations. They want to know everything. And just like we always learned in class, it depends is the number one answer in PT. So, we set up a rotation sometimes a year in advance, and a lot can happen with staffing in a year. So there's a lot of juggling. It's very dynamic. We have to reschedule rotations. Employees become pregnant, or perhaps they're getting married during the rotation. So I will change the CI assignment so that, I don't want to put the extra stresses and work of having a student, which it is extra work and extra stress because we're very engaged in education and we want the students to have a great experience. But I don't want to put that extra work on somebody, during a really important time of their life, like when they're getting married or just coming back from maternity leave or something like that. So it's a very dynamic process. There's a lot of mentoring with the staff, trying to get them to remember what it was like to be a new grad and realize that they didn't always have this 15 years of experience and this 15 years of practice knowledge. And sometimes just mediating the discussions and making sure people are hearing each other correctly, connecting students with resources of their schools. Students tend to find their schools as a punitive resource. Please don't contact my school. But the schools are really there to support the students, and they're also there to support the clinical instructors. So really working as basically the clinical DCE. So I'm the clinical side. In academic programs, it's called the DCE, the Director of Clinical Education, and then on the clinical side, it's the Site Coordinator of Clinical Education.
Wow. I mean, it just seems like there's so many things going on within that. And I'm curious how you kind of juggle it all. But, given all those duties, what about, this position do you find is the most difficult? Like, what are the most challenging avenues of this job that you usually have to encounter?
Right. So there's a lot of variety in the job, and just the forms. March 1st is when we get our requests for clinical rotations for the following year. So again, we're planning in the future, and all we can do is kind of give our best guess. But every form that we get from the schools is different. There have been some efforts to get coordinated forms so that there's less variety, but each school still tends to tweak the forms to meet their needs. So in essence, it really is just a different form for every school. Time is a big aspect. Clinicians need support from me. The students need support from me. It kind of has turned into a 7-day-a-week job, and I have a hard time personally, not meeting that 7-day need. I seem to work 365 days a year, and that is by choice, just because I want students to walk in feeling prepared. And when a clinician is in the clinic and they're very busy, I need to be able to respond to their needs so that they can meet the patient's needs and the student's needs as well. There are a lot of changing regulations with third-party payers, changes in laws for access and disabilities. So how are we going to meet students that have learning disabilities? How are we going to meet their needs? And then knowledge of individual state practice acts. So we practice in Illinois and Michigan within OSF. However, our students come from all over, Nebraska, Connecticut, just all over. So the practice actually applies to the state they're practicing in, but we need to be able to speak to that with the students, and we don't want to put them in a position where they feel they're having to make a choice between two rights. So there's a lot of other knowledge that needs to happen with Practice Act. For my role, particularly, geography is kind of an issue. Our clinics, there are 15 hospitals and then their corresponding clinics, and they're spread over 2 states and hundreds of miles. So I can't be physically present to help in difficult situations all the time. I do use technology as needed. And then if there are specific situations, I do try to do a site visit so that the clinician and the student both feel supported.
Yeah, given all the things that you had really just mentioned there, that's clearly a lot of things, and I give you strong kudos for doing all that you do and putting the time in, because I know it's making a difference. But I'm going to back up and kind of ask, what do you think that most CI students or even DCEs are usually not really aware of when it comes to being an SCCE, or kind of your perspective? What are some of those more unknown or maybe things that people usually aren't as aware of regarding this position?
I'm not really sure about the position, but I think that in my specific position, I'm very supported by administration, so I have some time to actually develop a strong program so that we can hold students and clinicians accountable for educating. Now, not all site coordinators have that, so it's hard for DCEs because they work with hundreds of clinics. So it's hard to remember who has what resources. So I think that is one of the pros behind OSF having one person in my position, because it's easier to identify coincidences and similarities between all locations in one organization. I don't think students don't realize the connection that we have with the schools. So, we do unfortunately still get many students who think they're very, very smart and they're pulling something over on us. But we are in close communication with the schools frequently, and that is to build the profession. And that's what it all comes down to. It's the relationships that students are making with their CIs and vice versa, also with their patient, who is of utmost importance. And then the school support and the clinic administration support to create an environment where we can build that knowledge and create a strong foundation for the future of our profession.
Yeah, and you had mentioned part of this earlier, Chrissy, but I just want to reiterate this point. Were there any, besides of course having a heart rate and a pulse, were there any other specific continuing requirements that SCCEs have to do? Is there any kind of overseeing regulation or any things that they have to meet to stay at this position, or no?
There are not. Of course, there are lots of things that we can recommend. I think being obviously a member of the APTA is extremely important. There are news bulletins and resources that come out at lightning speed, and the APTA has been instrumental in getting that communication out. The APTA has also been collaborating with leadership for the AOTA and ASHA when we recently had some concerns about Medicare maybe not paying for student services in the inpatient setting as well. So they were very agile and responded to those concerns. And had you not been a member, you wouldn't know what was going on. So you would potentially be practicing with a student in a really volatile situation. The education section has a conference every year, the Education Leadership Conference. It's held in October, and I've been going for probably 10 or 15 years, and it is a really great conference. It started really from the academic perspective, but they have been really trying to grow the clinical perspective for the last probably 5 years, such to the point that there are academic programs that are sponsoring clinicians to come, like helping pay their way. There are, I believe, 40 scholarships that are awarded by ACAPT and the APTE so that more clinicians go. And it's really great to build relationships with the academic partners. I think one thing that clinicians, especially clinicians that went to school in the 80s and 90s, when we were students, we were with our CI all day long, connected at the hip. And that's really not where education is. It is very valuable to have time away from your student so you don't go crazy. And so they have a little autonomy. They can sit and think and reflect and have time to synthesize the information they've just seen. It is great for them to go with a case manager or with an occupational therapist or a nurse, to just see healthcare being delivered as well as physical therapy or, their PTA curriculum.
Yeah, no, I mean, that seems very, very logical. And Chrissy, I know that, given your experience with this position, I would just kind of really like to kind of give your insight on this next one, because I recognize there might be some newer SCCEs that are kind of coming on board, or maybe even others that might be struggling. So what have you found from your perspective that tends to usually work most effectively with coordinating clinical education from your sites? Like, what have you found works versus what hasn't?
So administration backing is crucial. A site coordinator needs to have the time to support and develop good clinical education, creating a curriculum. The clinical credentialing instructor program level 2 has been redesigned, and the focus on that program is on creating a clinical curriculum. I had already taken the advanced course. We are hosting the level 2 course coming up in February. And so I actually just attended that course this past weekend with one of my coworkers to kind of preview the content so that we could see how the course would be most useful for us, so that when we bring and host the course with OSF, it is our staff that are working in a collaborative fashion to create the curriculum for students, instead of me in a site coordinator role saying, here's the curriculum to follow. I think when there's collaboration among the staff, you're going to get, number one, better buy-in, as well as what's reasonable and practical. They are the boots on the ground in the clinic. So administrative backing is crucial. Communication is key. What are the expectations of the employees? Do all employees have to have students? Maybe, maybe not. It is an expectation at my facility that all employees take students. I will say, though, that some employees are not good clinical mentors. So what that means is more work for me, mediating, getting them the resources, helping them teach, helping identify student learning styles, things like that. But at some point, I think we need to evaluate the skills of someone as an educator, because these students are paying a lot of money and the outcomes are critical. So if you don't have a good instructor, it couldn't meet the students' needs. So I think we're constantly looking at whether or not everyone should teach. Do they need to step up and learn how to teach? Or do we want to say, some people just aren't cut out to be teachers? The reason we took the approach that we felt like all of our staff should teach is because we all teach patients. So that was kind of the foundation. But, it's just clinical education is always changing, so you have to be very dynamic. One of the things that it surprises me to this day, I'm still developing some norms. For example, the clinical CPI, Clinical Performance Instrument, has classifications of simple, complex, and highly complex for patient types. Now, in my practice, my clinical practice, I worked in the neuro ICU for a long time. So it would be very common for me to see somebody on an oscillating ventilator with a ventriculostomy, on a rotating bed. Those kind of things become simple after a while. However, a student walks into that room and sometimes passes out, honestly. So we had to really step back and say, what does simple look like for a novice clinician? What does complex look like? And then at some of our trauma centers, what is highly complex? We wouldn't expect a student to handle. We could expose them to that, but we certainly wouldn't expect them to handle it. So we've had to really come up with some standards, common definitions. What is simple? What is complex? What is our productivity standard? Productivity is not a focus for us with our students. However, students need a number that they can target. So we did come up with a number that we want them, what does 50% of a schedule mean? What does 75%? And that's graduated for a student, because we don't expect them to function and make those automatic clinical pattern decisions that we make, with 20 years of experience. So just the development of forms and standards at our facility, it still happens, and I've been doing this for a long time, and I think, why didn't I develop this before? But things always pop up.
Yeah, hindsight's always 20/20, isn't it?
Yep.
Yeah. And, Chrissy, given that, of course, you work with, of course, not only just the students and the CIs, but also the DCEs in the schools, I'm really curious because I know we're probably going to have a few DCEs on. What can DCEs do best to help support an SCCE in their role? Like what are some things that a DCE can do from their perspective to assist the SCCE in advancing and doing kind of the stuff that they're doing?
I am very fortunate to work with some great DCEs. I think that has something to do with being in the Midwest, where we're all real friendly and we like to get along. So we're really collaborative and cooperative. They take my feedback and integrate suggestions for change. They are open to providing me feedback on individual mentors or on our program overall, so that we can improve and change our program. And so I think, like I said, in the Midwest, it's very cooperative and collaborative. I know sometimes I go to the national meetings, and especially in the New England area, there's a really densely populated proliferation of schools, and so it's really competitive to get those clinical spots. And so I feel that competition even in meetings, and it's often in the Midwest where people will work together to use spots or not. And there's maybe a three-way conversation going on between myself and two different schools saying, well, I could give you this spot if you can give me that spot. I would love to see all programs, all DCEs adopt recommendations, such as like the forms that we talked about earlier. So when something's put out by the APTA, not tweaking it to meet the school's need, those kind of things, it becomes confusing and extra work for the site coordinators. I do have several DCEs that return all of their student clinical requirements to me in a packet. So like, for student John Doe, I will get all 5 attachments from the DCE. So I know they've met all of their requirements and they're ready to go on their rotation. From my perspective, I love that because it's easy and everything's done. What it doesn't do is facilitate independence on the student's part. So, there's some pros and cons to that approach, but it does make that easier for my job.
Well, and that makes sense. And I think it's really interesting when you kind of said just how it's different in the Midwest with those kind of relationships. What do you think is unique besides, of course, the people in the Midwest just being awesome? Why else do you feel like that is unique to why do you feel like what else is the Midwest doing in that situation that's different? And why do you think that a model or collaboration of that level isn't happening across the country?
I really think it has to do with the population of schools in geographic regions. So the Southern California area has a lot of PT programs. The Northeast has a lot of PT programs. Florida has a lot of PT programs. And even though there are quite a few in the Midwest, they're spread out. There might be 4 per state. When you're talking about Missouri, that's a decent sized state, but you're talking about Massachusetts, that's a lot smaller state. Now, people-wise, it's not. But when the geography is more spread out, you have more clinics just in numbers to reach out to. And then, like you said, the Midwest is awesome.
Well, I mean, we're not biased or anything. We're not from the Midwest or anything. So let's just throw our biases out there. You'd mentioned, of course, a little bit earlier, a few things, of course, one of them being having to sometimes set realistic expectations for the CI of the student and kind of navigate that. But what are some of the other bigger concerns that you hear from CIs kind of being in your position?
A lot of things. There's some concern about anxiety, student anxiety and student mental health. They have a lot on the line by the time they come to the clinic. And in general, especially PT students are very smart. They're academically inclined, and putting that all together and then talking to people can be, number one, scary. Number two, they're in an environment away from their support. And sometimes they really freak out. So we've had some real crucial instances with our students where, first of all, you just try to be human to them, but you also have to hold an expectation. When you get out into the working world, you're going to be expected to come to work and perform 40 hours a week and leave your problems at home, and deal with the patient in front of you because they are paying a lot for your services. And in the time of direct access, we need everybody, all of our clinicians, to really be focused to elevate our field and then the acknowledgement, notoriety, acceptance of physical therapy as a practitioner of choice.
No, I mean, I think that seems really, really logical. And I mean, given that, I mean, because you kind of, I mean, you want to be empathetic, but also realize like, this is the job. This is what's going to happen. And I completely concur. And I think, and I'm going to be a little biased here because I feel like in some ways I was shielded a little bit too much. And I think that kind of did negatively contribute to feeling like getting hit with a bus a little bit later. But so, and I don't know what the right balance is for that. I don't know. You know, it's interesting because we were talking a little bit about forms and staying consistent and organized with that. And, you know, Carol actually had mentioned on her podcast episode that the thing she would like to see changed about healthcare education was a specifically centralized location in which had all the clinical education information that could be easily accessed from one location. What are your thoughts on this? And do you think that this will be a reality in the near future?
Well, I hope it will be a reality. I completely agree with this concept. I was actually at a conference this past weekend with Carol, and we were talking about it again. It seems that there should be the potential for this to occur because the APT has already gone to the centralized application process for both, professional programs as well as residency and fellowship. So there needs to be some kind of coordinated effort and resources put forth by the APTA to manage, because this would really fit in the category of big data. There certainly, though, are requirements that every student is going to have in a clinic: CPR, vaccinations. Maybe we should have a learning style inventory. How does the student learn? A student profile, the syllabus for the actual clinical course they're in. So basically, a unified approach from all schools. What do we, in clinics, what do we need? And let's put that in a centralized location. That actually has come up. I'm on the board of directors for the National Consortium of Clinical Educators, which is a consortium of ACAP. That is something that I brought up a couple months ago. We have a lot of irons in the pot right now, though. The interesting thing about the NCCE is that it is focused on the partnerships. So half of the participants are academicians and half are clinicians. So it is that partnership that clinical education isn't just the afterthought of the PT program or kind of the final stepping stone. It is an equal partner to get the student to entry level. I would say the one thing that comes to mind is maintaining the accuracy of the information is a problem. Through the CPI, there is a data collection tool called the CSIF, the Site Specific Information Form. But when you're talking about some clinic administrations who don't really support the role of SCCE with dedicated time, that is the very last thing that's going to be on the to-do list, is to update that CSIF annually. So that would just be outdated information. So if it could be easy to do, not take very much time, and be standardized, and site coordinators would have supportive time from their administration, I think that could be done very easily. We have also recently been talking about some regional consortia placement processes. I personally am not in favor of a centralized pool for clinical placements. I really actually started to grow the partnership model between individual academic programs before it really became a national focus. I just find it easier to work with, say, 20 schools closely than 50 schools and not really have a good knowledge base on what they expect from their students. So if we have a centralized pool of clinical placements, we can be taking students from schools that we don't know. Not that those schools are bad, but you just don't have the level of comfort and knowledge of what they expect, what they've been taught, what their approaches are, and it leaves gaps for the real talk conversations that need to happen. So if a student is struggling, it's much more difficult for me to pick up a phone and talk to a DCE when I don't really know them. And are they focused on academics? Are they focused on professionalism? Are they focused on mental health? Are they, have high expectations, low expectations? So therefore, I'm not really in favor of a centralized pool for clinical placements, but for standard repository of clinical information, as well as academic information on programs, I think that would really serve the profession well.
Let's talk a little bit more about the students. What What characteristics do you see as the most important for students to demonstrate during a clinical placement?
I would say professionalism. And to me, that means timeliness. Do they know what the social norms are in a work environment? I would prefer that a student is interested and engaged in the clinical content, even if it's not their self-identified area of practice preference. So especially coming from acute care as my area of clinical practice preference, so many students come to their acute rotations and they already know they're going to work with peds, or they already know they're going to work in outpatient orthopedics. But what they have to understand is the patient had to go through acute care before they made it to outpatient, before they made it to rehab. And so what's the foundation? How far has the patient progressed? And having that experience and knowledge is really important to the latter rotations, and vice versa. When I did my outpatient orthopedic rotation, I hated it. I don't like orthopedics. I still don't. But it was really valuable for me to validate exercise prescription, biomechanics, all of those things that, guess what, I use in acute care as well. So I really need the students to be interested and engaged. I feel like clinicians, almost even more than teaching students physical therapy, should be teaching them communication and professionalism and resourcefulness. So I'm not going to remember, every bone in the body forever. But if I forget, then what do? I go look it up. I think back to my biomechanic basics, and I can go from there on the foundational principles that I learned a couple of years ago.
Yeah, I mean, it sounds like you're basically saying kind of facilitating them to be kind of lifelong learners, because you're right. In the real world, at some point, that skill is going to be pulled out at some point in time, because when I was an adjunct teacher, one thing I made the undergrad students do was you're going to write a research paper on a condition you've never heard of before, because you're going to have to research it, find out all about it, tell me how your treatment would modify, what do you have to look out for, because it's going to happen at some point. I mean, it's not a matter of if, it's a matter of when, and you need to be prepared and know how to find that information and how to learn about it and how to adjust accordingly.
Right. And one example that just comes to mind quickly is, I had a problem with a student in the previous spring, and the student didn't want to engage with the patients because they hadn't seen that yet. They hadn't seen an ACL repair yet, but they had seen a total knee. So they were on their last rotation. And so we had to come down to, you're not going to see everything before you graduate, but you've seen a post-op patient, you know the knee, what resources can you find on your own to pull those pieces together? And I think that's really where a strong clinical instructor comes in, is, not giving them the answer, but making them stand on their own 2 feet and find the answer.
Yeah, no, I completely agree with that. And, kind of just a random side question here. What do you like the most about seeing and helping students in the clinic?
Oh, there are so many things. I adopted the collaborative model early on in my clinical experience. So having multiple students at one time and watching the students work together, it allowed us to be much more aggressive with our patients because I had extra sets of hands, extra sets of semi-skilled hands at that point. I love their aha moments. I like teaching them to become reflective practitioners. Most importantly, I really enjoy teaching them to see patients as people and the value that they bring to teach the students as well.
Yeah. And, Chrissy, it's been interesting because I've heard, I think it's been interesting how clinical education in terms of length of experiences has certainly changed. I mean, even since I was a student, I had a 6-week and then 3 8 weeks, and now I'm hearing a lot of schools are extending to 10 or 12, sometimes even longer. I'm just kind of curious where, from your perspective, what is your viewpoint pretty much on kind of the longer clinical rotations compared to more like a 6 to 8 week rotations? Like, what have you found that's kind of unique with those?
So I think clinical education is tricky because there's a capacity issue in certain practice areas. So if we lengthen the clinical education experience further, it would reduce the opportunity for students to experience the variety of clinical settings. And our goal is to graduate entry-level generalist practitioners. However, new employers have high expectations for new grads. So longer clinical rotations might prepare the student better for a specific practice area, but leave them lacking in another practice area. But I think, remembering back to the foundation that we're trying to graduate generalist PT practitioners is important. So it might be as important to instill the values of work ethic and professionalism, quest for knowledge, utilization of resources, instead of advanced clinical education experience in niche practice areas. So, one example that comes to mind is dry needling. It's being taught in entry-level programs now. If we keep adding content to these programs, they're going to continue to lengthen in time and therefore cost. And student debt is a huge issue for students, which is impacting their anxiety and their mental health. So at what point do we say this is the end of generalist entry-level practitioner, and something like dry needling, maybe that's advanced, and that is something they're going to have to go through certification for after graduation. There are so many areas that are developing in rehab and in physical therapy that I don't know that it's possible to teach the students everything. So we've done some informal surveying of students and also clinical mentors, and it seems to be that 10 to 12 weeks is kind of the sweet spot. It gives the students long enough in one setting to gain confidence and experience, and then have time to practice in a setting that they're familiar with and with staff that they've gotten to know before we upheaval and send them off to a new site. So through the literature, we know that mass practice is important for skill mastery, and we tend to think of that as one skill, like throwing a ball repeatedly. But clinical education is also skill mastery. So if we give them a supported environment and allow them to practice a similar patient population for a while, they will gain more mastery. I said before that productivity is not the focus of our student program, but we do also need the rotations to be of a sufficient length that the students actually end up being a little bit productive by the end, so that we have a neutral overall cost for our students, because there definitely is a decrease in productivity in the beginning of the rotations when we're onboarding the students and the therapists are doing a lot more teaching and education. So once they've gained some independence and some autonomy where they're safe and appropriate to be independent with the patient, we need enough time to kind of recoup our productivity losses.
Christy, I know this is a huge question here, and this could probably be a whole separate podcast episode of itself, but I want to kind of just get what your big answer would be. If, what do you see are the biggest glaring issues in clinical education across the country, and how would you recommend optimally addressing them to move forward in the best way we can?
So I think the biggest concern right now approaching us is the proliferation of academic programs. There are PT and PTA programs that are developing in the numbers of 10s to 20s each year. And if we have a capacity issue for clinical education sites, I'm not exactly sure how we're going to teach those students to be competent practitioners. So I'm not really sure how to address that. I understand free market. I understand, as long as they're meeting CAPT criteria, those kind of things. But there is definitely going to be an impact on the clinical education sites. So I think that's a big problem. The student loan debt is a huge issue. Some clinical sites are now requiring a fee for placement. So then I wonder, are students going to free clinical rotations because they don't have to pay more? And then are those free clinical placement sites substandard or not? I certainly know both sides of the story. There are some task forces looking at payment for placement rotations, but I just have a lot of concerns about requiring payment to come to my clinical setting and interact with me. I don't feel like that's very collaborative. We definitely have areas for growth in our IT infrastructure for better use of the CPI outcome data. One of the kind of big themes that I see is that clinical education experiences really seem to be approached by the students as a cost issue. How much will it cost me to go there for housing, for travel, to meet their dress code, et cetera, instead of what is the value of experience? Having been in different areas of practice in my career, I can tell you that you will not learn more from any setting than home care. It's not my preferred practice area, but for a student to choose home care for a clinical rotation is probably the best decision they could make. And very few are choosing that. I think there are fewer opportunities in home care overall. Rural healthcare, how important it is in meeting that generalist need. There are physician providers who are not going to rural areas. So if PTs go there, can we fill that primary provider gap? Potentially. And so I've spoken again, another issue is the student mental health issue. The expectations are high. We have students coming out that are letting us know on their final rotation, they're struggling in their rotation, but they owe $200,000. It's really hard for a clinician to fail that student. And I know the clinicians don't fail them. We just observe and evaluate, and then the school passes or fails them. But it's really hard not to be empathetic towards someone who owes that kind of money. But yet there are no guarantees. Nobody guarantees when you graduate from med school, you're going to pass your boards. Nobody guarantees you're going to pass PT school. So we do still have to hold a high standard of care, but we need to be concerned about the students' mental health and how they're doing all along the continuum.
Yeah, and one other thing that I want to add on to your first point that you had brought, I think you brought up so many good and valid concerns. I think that we could dive into all of them within a long time. But, back to the proliferation of programs, I know apart from the things you had said, one more thing to add on there is, of course, then there's the concern of faculty shortage to be able to fill the roles of those new programs. And are we going to get qualified faculty or are we not? And that's a question that I think is being examined, and I don't know the answer to that, but it's certainly a concern. Chrissy, of course, our final question, and doesn't have to be involved with clinical education. This can be anything healthcare education related. So our big question is, if you could change one aspect of healthcare education, physical therapy or otherwise, which aspect would you change and how would you change it?
Well, I don't have all the answers, but I think that the area of academic obesity is really a problem. And I think that professions need to identify what is that entry level graduate and really reinforce that and hold all academic programs accountable to that. So I previously used the dry needling example. Lymphedema is another one, aquatics. It's one thing to expose our students to that. It's another thing to include competency curriculum to the content of their didactic course and increase the cost of education, because then that snowballs into anxiety, mental health, and all of those other affective issues that we see in the clinic.
Sure. And I know this gets back into kind of like really what should curriculum focus on. And I know we actually recently had done a poll on Twitter asking, and we got over 700, almost 750 responses on what would you like to see better addressed from a didactic standpoint in entry-level education. And the choices were exercise prescription, strength and conditioning, pain neuroscience education, business, and then population health. Guess which one won?
I would say exercise prescription.
50%. Yep. Pain neuroscience was second, and then it was close third and fourth between business and population health. Now, this is not absolute. This is an informal Twitter poll, so let's keep that in mind here. But I will say that I think there are some things that I think that are being addressed to help that and kind of help figure out what are those things that all clinicians need. And exercise prescription and those kind of principles seems to be one of the most common things I hear among students and new graduates. It's an area they feel weak in. And it makes sense. I mean, that's something every provider, no matter what setting to some degree, will do. I mean, you're going to have variability in how you apply it. There's different considerations, but we have to know how to prescribe activity.
Right. And of those four categories, the four answers that you gave, really two of them hit on the profession of physical therapy. The other ones are on maybe a branch. We need to be aware of the business perspective. But if you want to run a clinic, then after PT school, you can go get your MBA. You can go further your education in business perspective. So there needs to be, some basic level presented in school. But I think what happens is the academic program directors want their programs to stand out. And so they, add content, and that just adds to that academic obesity.
Yeah, no, it's certainly a big topic, and I know there's way more to dive in on that. But, Chrissy, I really appreciate your sharing your perspective on kind of clinical education and your role as an SCCE, because it's definitely been insightful to me, kind of learning from your perspective and kind of seeing that a little bit. But I recognize that some people listening might also have questions or maybe want to learn a little bit more. Where would you recommend that people look online for either more resources, or if they wanted to reach out, should they have a follow-up question?
Sure. So the APTA's website, the APTA, formerly the education section, it's now the Academy of Physical Therapy Education, has a wealth of knowledge about clinical educators and the site coordinator role. There is a site coordinator for clinical education resource manual on the APTA website. And then in October each year, that Education Leadership Conference has content specific to site coordinators, as well as it's just a really good conference. And the content is really scheduled around the collaboration of education. So academic, clinical, administrative, all aspects. And then otherwise, I would recommend people reach out to a local academic program, reach out to the DCE and say, do you have a site coordinator that you think is doing a good job that could answer some questions for me? I know I get questions all the time from site coordinators, new site coordinators in my area. And I answer them. I'm not sure if my administration wants to know that, but I think it's about collaborating and building a good culture of clinical education. There are plenty of students to go around, and it's about building the profession more than building my site.
No, I completely agree. And I think that's very admirable of you to do that. And Chrissy, thank you so much again for your time and insight. It's been great having you on to learn from you, and looking forward to see you at ELC.
Sure, I'll be there. Thanks for having me, Brandon.
Of course. Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available on our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.